What if your next patient isn't just having an autoimmune disease, but having Lyme disease at the same time? This is a question that came up in a letter to the editor. I'd like to discuss this case as part of a common sense Lyme disease presentation where I discuss cases I've seen and questions that have come up and what I've read in the literature. And this will be followed with a quiz, so get ready. This is an article called Lyme disease as an extremely rare cause of Guillain-Barré Syndrome in India. And this case discussion brings up a lot of issues that are important. In this paper in 2020, Guillain-Barré is Guillain-Barré. We don't hear much about this autoimmune coming from another illness like Lyme disease. This is a 50-year-old woman who had symptoms like slurred speech, dysphagia, limb weakness, and numbness. Fever, vomiting, diarrhea, no tick or rash, but some kind of prodromal symptoms. So, bulbar palsy, this dysphagia that the patient presented with, facial nerve palsy, but it wasn't just one side, it was both sides. Hypotonia, absent reflexes, and the nerve conduction studies showed demyelinating sensory motor polyneuropathy. So they diagnosed with Guillain-Barré, but sensory motor neuropathy is also seen in Lyme disease. And this was a 1990 paper by Lygidian and Steer. Now, the diagnostic clue that led them to look past the Guillain-Barré was this bilateral facial palsy. And that led to an infectious disease workup. The Lyme test happened to be positive, which isn't always the case. The final diagnosis by the authors was Guillain-Barré Syndrome, which is an autoimmune disease, or considered autoimmune disease. In this case, it was secondary to Lyme disease, according to the author. This patient was treated with intravenous immune globulin, IVIG, for Guillain-Barré and IV ceftriaxone, but because of the neuropathic pain, a prescription of gabapentin was given, and with time, there was a full neurologic recovery, according to the authors. Now, the authors didn't discuss whether there were any long-term problems, because some patients have long-term neurologic issues, fatigue issues, and other issues. The key learning point from this letter to the editor was that Lyme disease is rare, but a treatable cause of Guillain-Barré syndrome. The cranial nerve involvement in this case led to the early clue, then the positive blood test. And this patient had a good outcome, likely because of the early diagnosis, but also the tailored treatment involved treatment for Guillain-Barré and Lyme disease. So the take-home message is in patients with atypical Guillain-Barré syndrome, particularly with cranial nerve involvement, Lyme borreliosis should be considered. This was the reference by Varma in 2020. So let's go ahead and ask some questions and answer these questions based on what we've just reviewed. What initial neurologic symptom did this patient present with? In this case, it was difficulty swallowing. So whenever this happens, you don't necessarily suspect a broader issue. So there's two sets of nerves. What did the nerve conduction studies revealed? This was demyelinating sensory motor polyneuropathy. And I mentioned that in the discussion, is that motor is more of would affect function. Sensory is still a dysfunction, makes it difficult to deal with the symptoms. What infection was ultimately linked to the patient's Guillain-Barré syndrome? In this case, the cause appeared to be related to Lyme disease. One antibiotic was prescribed, ceftriaxone, because ceftriaxone is seen as the only drug that can cross the blood-brain barrier. Step in managing patients with Guillain-Barré syndrome and Lyme. I feel that I would have done the same thing treating for Guillain-Barré and Lyme with IVIG and IV antibiotics at the same time. Now, this is a bonus question where you get to address this in the comment section. So, which of the following statements is most accurately regarding Lyme disease in a non-endemic area? Is it A, Lyme disease cannot occur in regions outside the Northeast? Lyme should not be tested unless a rash is present. Clinical suspicion should guide testing, even in prevalent areas. A negative PCR definitively rules out Lyme disease. So thank you for joining me for this Common Sense Lyme series. Have a good day.